So I have 8 o'clock, so I'll begin with the introduction. By the time we're done, we'll probably be ready for Dr. Seitz to get started. I wanted to introduce myself. I'm Dr. David Russo, and I'm the Veterinary Clinical Director at Butterfly, and really thrilled to be here tonight to be sponsoring this presentation of getting familiar with point-of-care ultrasound. Tonight, our presenter is Dr. Marc Seitz. He's an associate clinical professor. I can't talk tonight. Clinical professor of diagnostic imaging at Mississippi State University. I'm going to let him introduce himself a little bit further once we get started. I wanted to remind everyone that we are approved for 1 hour of CE credit through RACE in the jurisdictions where RACE is recognized. So you'll be getting your certificate within the week at the email address that you provided for us. And also feel free to ask questions as the presentation proceeds. You can enter them in the chat pod and we'll either answer them right away or towards the end of the presentation. Let's see, we're about at 8:01. So Dr. Seitz, I'm going to let you take it away and I'm here to help out.
I love it, David. Thank you so much. Y'all, welcome. I am so excited. For those of you who know me, and David's kind of caught on by now, we've known each other for a little bit at this point, over a year. I love ultrasound, and I love getting to share ultrasound because ultimately it positively impacts our patient care, and that's why we're here today. Before we get started, I did want to give a huge shout out to Butterfly. I wanted to thank them for a couple reasons. One, they are just very passionate about bringing high quality ultrasound education to veterinarians. And when they approached me a couple years ago to do our first webinar, it was purely as, hey, we just want you to teach content. And I love that. So I'm here as an independent person. Ultimately, if you have questions for the sales team, David can direct you to the right people. But this is not intended, obviously, to be a sales pitch. It's intended to teach you and just show you all the wonderful things that point-of-care ultrasound can do. So thank you, Butterfly, for just allowing this content to get out. It is amazing. Just before we get started, I want to let you know that my name is Mark. I graduated from Mississippi State in 2007, and my life has not always been that of radiology. Like a lot of you, I was in private practice, and I was in a combo of GP and emergency medicine for about a decade. I did GP for 3, emergency for 5 years in Atlanta, New Jersey, respectively. During that time, I got boarded canine feline practice, and I was loving it, but I was also doing a lot of ultrasound. I even made the stupid comment one day to a radiologist, man, I wish I could get paid to do ultrasound all the time. And he just looked at me and I went, no, because I was very much tied to emergency medicine at the time. But what I came to realize is that all the things I loved about ER are in radiology as well. And I love all aspects of imaging, which is great. So completed a second specialty in 2021, and I'm now a clinical radiologist for Mississippi State, meaning I'm on the floor most of the time, but they fortunately support and allow me to do wonderful stuff like this. So with that being said, whenever I teach, I want you to know I'm coming from the perspective of that private practice background, not trying to turn you guys into radiology residents. And my goal is to give you several Monday ready skills, or Thursday, be it that it's Wednesday, several skills that you can immediately start using tomorrow, especially if you have an ultrasound in your hospital already. So with that out of the way, let's get started. The goal of today is to delve into point-of-care ultrasound. And what I love about it, it is both valuable for patient care and sort of your introduction to build more skills upon. So when we're talking about it, it's important that we define what it is so we don't confuse it with a full diagnostic ultrasound. Point of care is when we're using the ultrasound in a very limited fashion to answer a clinical question. And usually it's going to be a question in a yes/no format. And the one that we're all familiar with, does this animal have abnormal fluid where it's not supposed to be? The most common one is looking in the abdomen for peritoneal effusion. And the thing to note is that this is a newer term, and I say newer, we've been using this terminology for 5-10 years now. But these exams historically have been called FAST scans, for focused assessment with sonography for trauma, because they were developed in human trauma centers, in ER. Well, what we have quickly come to realize, especially in veterinary medicine, they are just as useful, if not more useful sometimes, in non-trauma patients as they are trauma patients. And so the emergency and critical care community has kind of moved towards the phrase point of care because it better describes how we're using ultrasound, but it is still perfectly appropriate to say point of care, POCUS, fast, focus. I'm going to use them interchangeably because I've been doing this for a while now. And I still remember some of those original studies coming out validating the first fast techniques for veterinary medicine, which is great. So the big thing to keep in mind, they are not intended to replace that full scan that general practitioners and specialists do. So what are we going to do with point of care? For the purposes of this lecture, we're going to give you the skill to evaluate the abdomen for peritoneal effusion, but we're also going to introduce you to your first limited organ exam and show you the value of doing just a quick screen to make certain there aren't game changers that could cause your empirical therapy to fail with lower urinary patients. So, the thing I try to impress on people, there are lots of point of care tests we won't cover today. And I always, tell my students it's mainly intended to find fluid in the 3Ps: peritoneal effusion, pleural effusion, and pericardial effusion. Because of this, it's really helping us to triage who's stable and who's not stable. And it's going to help us guide further diagnostics. I can't tell you how many times I've had an animal come in and they come in for anorexia, vomiting. They're looking like a GI workup. And we do our abdominal point-of-care ultrasound and find pleural effusion. And we're going to talk about that, how you can find pleural effusion sometimes from that one of the abdominal locations. And the other thing that's nice is it helps complement some of my other tests. So many times in general practice and emergency, I would get my blood work back and go, wait, anemia, that's weird. Wasn't expecting that. Or, hey, there's a elevated liver value or renal azotemia. And I wanted to check and make certain that there wasn't peritoneal effusion that could indicate a more serious condition. Equally for thoracic point of care, I love it. It's a great complement to my thoracic radiographs. I mean, all of us out there have sat there and looked at a cat radiograph and gone, is it interstitial? Is it bronchial? Is it heart failure? Is it asthma? Thoracic point of care can really help answer that clinical question. And perhaps maybe we can do a thoracic point of care lecture at some point for y'all. But at this point, we're going to focus in on this abdomen. And so the logical question, when are we going to do it? And the answer, whenever an animal is generally sick. I hate textbook things of, if this animal walks in with A, B, C, whatever. This study sort of captured it. They did point-of-care ultrasound on every pet coming into the emergency room at their particular hospital. And these were walk-in emergencies as well as tertiary care referrals. And what they found, out of 100 patients, 1/3 of them had peritoneal effusion, pleural effusion, or pericardial. It's pretty significant if you look at point of care as a screening test that you're going to be screening and find abnormalities in about 1/3 of your patients in an emergency population. I recognize in GP it may be a little bit lower, but what's really important that came out of this study is that if we do that good triage exam, which we're always going to do before point of care, and we evaluate that animal to be unstable, meaning they're having trouble breathing or they're in shock, any other cardiopulmonary vascular compromise, 3/4 of them are going to have an abnormality on point-of-care ultrasound. And often these abnormalities end up being very clinically relevant to how you stabilize them and work them up. So if I'm in GP, am I going to do it on the broken toenail or otitis? Absolutely not. But if that animal comes in anorexic, vomiting, diarrhea, acute abdomen, fever of unknown origin, I love it for. Anything of that nature, trouble breathing, we're going to do it. And same thing in ER. There's a huge argument to build it into your emergency fee. And fortunately, the clinics I worked at, they did that. We even do that at state. Our clinicians are allowed to do a point-of-care ultrasound with that emergency fee that includes the physical exam. So I think batching it into your sick visit makes a lot of sense, and it can really help increase utilization, give you practice, but more importantly, catch things that you might otherwise miss. So I just like to drive home. You do not have to break the bank. I get questions all the time about what should I buy? And sometimes we get sticker shocked. We look at the nice diagnostic ultrasounds that can cost 40 to 60,000. At state, I scan on one that is north of 100,000 because we're at a research institution and we scan 8 to 10 times a day. But what you have in front of you are all machines that lasted 15 years, were used. And now Dave and I joke about it. If you had told me when I was graduating that I would be pulling an ultrasound out of my pocket in front of a client, I would have said, nope, nope, you're teasing me. This is not real. Because this was back when cell phones were taken off. I didn't get my first cell phone until midway through vet school. But we're at that point that for, very economical pricing, you can bring ultrasound for the purposes of point of care, cystos, and it amazes me. It reminds me of when we all got video otoscopes and we wowed clients with these. Clients are just blown away when you pull an ultrasound out of your pocket and you start using it. So do not break the bank if you're limiting your scanning to point of care. Now, if you're looking to do diagnostic, we do need to have other equipment considerations, and that's fair too. So accessibility is so important to making certain point of care is going to be used in your hospital. We all have that triage table where we do blood draws or we do, the fecal sampling that we need to get in ER. My emergency folks, if you're on, this is usually your crash table or where patients come to the back to do that initial triage exam. This is where your ultrasound should be. This is what's going to increase utilization. Now, if you already have one, maybe you can't set it up there, but you need it accessible. What you don't want is to have the nice machine in the back where nobody's going to use it, or, your portable device locked in a closet because everybody's being protective. These units, I'm not going to say are indestructible, but they're made to be used and moved around, especially the portable ones. I totally get protecting a console, but laptops, portable ones that connect to tablets, phones, they are amazing. They are durable. They all have drop ratings. Use them, use them, use them. And in fact, if you have a nice one that you're protective of, you can probably create a business plan to purchase a less expensive one that connects to a tablet, etc., or a laptop, and utilize that so it's getting used. So as far as patient prep, this is where I joke we get to break all the classic radiology rules, and this is coming from the radiologist, right? And what I mean by that, we're not going to shave our patients, we're not going to roll them on their back, we're not going to use gel, because it's all about efficiency. So we're going to start with recumbency. Traditionally, all the techniques have been validated in right lateral recumbency, and more on that in a minute. We've got another position that works just as well. But right lateral is what they're validated in. It's easier to restrain them. It's more comfortable for them. In this picture, we have a single technician restraining a lab. I know that's not always possible, but it's possible for a lot of them. But the big thing is for our less stable patients, it is much safer for them. I've unfortunately witnessed animals being rolled onto their back when they're unstable and in shock, and this is enough to make them code or to destabilize. Now, as I mentioned, we're not going to clip the fur. Instead, we're just going to soak it with alcohol, part it. You only need a region about the size of a dime or quarter to get that transducer on, and that's what you're going to look through. You need a very small acoustic window. Now, for my emergency folks or my higher level hospitals, if you have a defibrillator, you want to avoid the alcohol, or at least be mindful of it, because there are reports, sadly, of it combusting and patients or personnel getting burned from alcohol catching on fire. So in these cases, you would just use gel, but it's going to be kind of messy and hard to clean up. If your patient is in respiratory distress, obviously don't lay them on their side. So this is mainly for thoracic point of care or for unstable. You can kind of modify your approach if you're working with the abdomen and they can stand or be sternal. But this is a cat that had pleural effusion. There was no way we were going to put it on its side. So I just modified my approach. It got flow by oxygen and everybody was happy. So if for those of you who've been doing point of care for a little bit, and even if you haven't, we love to get creative in veterinary medicine, right? And one of the things we have all done is standing point of care ultrasound. And what's interesting, like a lot of things in vet med, this has never really been validated in the veterinary literature. We all thought it was giving us similar results, but nobody knew until a couple of years ago. Buckley, fabulous clinician finishing up in her residency at Purdue, investigated this. And what we found is that fortunately, when you compare standing point-of-care ultrasound to look for peritoneal effusion with a traditional right lateral recumbency approach, because we're using the same points, they come to a similar abdominal fluid score, which we're going to talk about in a little bit. Obviously, the distribution of fluid is going to be a little bit different because gravity is going to have a different effect of where it pulls. But the overall big picture of yes, they have fluid or not, and more importantly, the abdominal fluid score and its severity agree very, very well. So standing appears to be fine. It has the advantage in that, some animals don't want to lay down. They can just stand there. If they're having trouble breathing, they can stand there. The thing to keep in mind, we did compare the agreement to a full diagnostic ultrasound, not surprising. Full diagnostic ultrasound is still kind of a gold standard and more reliable. Jury's still out on CT versus ultrasound. CT is probably going to be a little bit better because we're seeing cross-sectionally very, very nicely, but ultrasound is going to be a little bit better, or full diagnostic can be a little bit better than our point of care. Now, things to keep in mind when you're doing a standing technique: lighten up your pressure. I'm going to show you in the next slide what pressure can do. It can displace fluid out of the way and make it look less severe, or worse yet, make it disappear from the field of view at all, making you call that animal negative. The other thing to keep in mind, if you have any concern for pneumoperitoneum, this may not be the best approach, or you may have to depend on your flank locations, but we did not validate it for free gas, and free gas is going to rise. And we're putting our transducer for 3 of the sites underneath the animal. So we just have to be mindful that we may not see small volumes of pneumoperitoneum, but hopefully that will get investigated in the future. This is an example of honestly what can happen either standing or with them laying down. But if you apply too much pressure, remember, fluid is very dynamic in the abdomen and it will push out of the way. So on the left, we have what I would consider appropriate transducer pressure, and we see this large pocket of echogenic fluid. On the right, same animal. All I've done is push harder, and you can see there's a tiny black triangle. I've made that large pocket go down to a really small one, and I would falsely call that a small volume of fusion. If that is an exudate, I'm not going to be able to tap that. If that is hemorrhage, I'm going to think the animal's not bleeding that much. Whereas on the left, that fluid is contacting that near field. I'm going to be able to tap that, as well as if that's hemorrhage, I'm going to be more concerned that that is a larger volume of hemorrhage. So as far as general technique goes, we're going to keep breaking the radiology rules. Well, some of them. The big one that we're going to break is we're only going to use one plane. We have an expression in radiology: one view is no view. But with point-of-care ultrasound, what several studies have validated is that both planes agree with each other for just calling yes, no, there's fluid, there's not fluid. And what that does is it cuts our scan time in half and just makes it easier to learn as well. So we're going to utilize a sagittal plane or a long axis plane, which is what I've displayed on the screen below. And we're going to primarily use a microconvex or something similar to microconvex. Linear probes are perfectly fine too. They just have a little bit bigger footprint and operate at higher frequencies. What's nice, a lot of these portable and handheld ones, they look like a linear, but their technology and crystal, what they're doing is very different. And so they can operate at a very wide array of frequency. So don't think just by the shape you can determine, oh, I know what frequency this is. You really have to understand what its operating frequency is doing. All right. So the big key, all ultrasounds, regardless of who makes them, has where this white arrow is pointed, this little probe marker. Okay. That corresponds on the transducer to this side, which corresponds to the little probe marker in the top left-hand side of the screen. So 2 important things. 1, if you're scanning abdomen on your screen, you always want that probe marker on the left-hand side of your screen. And the reason for that, we just want to always be able to look at these images and know how to interpret directionally what is where. And the way we're going to get the cranial and caudal is we're going to take this probe marker and we're going to point it at the patient's head, no matter where we put it on the patient. So if we do that, it sets up an image that's like a lateral radiograph, where cranial is always to our left, caudal is always to our right. Now, we use the terms superficial and deep, or near field and far field, because What's on top of the screen is going to vary based on where I have the probe. The top of the screen corresponds to your probe contacting the patient. So this would be sort of the skin and muscles. We get into the abdomen, and then this is deep up against the dorsum if I'm scanning through the ventrum. So if on me, I scan like this would be ventral, this would be dorsal. Whereas if I'm scanning on the side, on the flank, then all of a sudden, this just became left and deep just became right. So near field, far field, superficial, deep work, but cranial and caudal should never change. Now, when we go to interpret for point of care, I love it because it's a lot easier. We do eventually have to recognize bigger organs and what they look like, but we're not getting to the nitpicky, oh, what's the echogenicity of this tissue? Is it coarse? Is it no. Mainly, we are looking for anechoic or black. Fluid does not create echoes, and that is why it is anechoic. Anechoic means absence of echoes. Tissue are going to be various shades of gray. And then kind of the paradox of ultrasound is that gas and bone are going to be a similar echogenicity. They're both going to create a hyperechoic surface, but they're going to differ in their shadow. The reason why I sort of point this out, it's very different from what we're used to with radiography, where gas is lucent or black and bone and stone are really, really white or opaque. Curiously, in ultrasound, what's the middle gray in radiograph land is actually the black substance on ultrasound. So just be mindful that both gas and bone are going to create a hyperechoic surface. So on this image, I've got fluid or bile that is going to be black. I've got liver, which is going to be our gray. And then this is gas in the stomach, which makes sense. I've got a hyperechoic surface where that beam is hitting the lumen of the stomach. The important thing to note, if there's a gas or a bone interface, you are not seeing beyond it. So I'm not looking in the stomach right now. I'm looking at artifact, and we call that artifact a dirty shadow. In this image, we have a urinary bladder. And again, this stone is going to be hyperechoic on its surface. It's curvilinear. And now I have a clean shadow because the beam gets absorbed. We don't get this reverberation artifact. So the big picture takeaway, fluid's black, tissue's gray, bone or stone is going to be hyperechoic surface with a clean shadow, gas hyperechoic surface with a dirty shadow. Now let's get into our technique. This is the abdominal point of care technique that has been validated by numerous authors. It's the similar technique that's used in human medicine. You'll see variations in how the locations are described. I'm in the camp, I like to describe these locations based on where we're at outside the dog. There are names that I'll share with you based on your targets, but the problem is they've undergone some changes. They're longer. And so from a teaching standpoint, especially when I'm working with veterinary students, I just find this is a lot easier to assimilate. So our first location is subxiphoid, where the number one piece of tape is. The next is the flank or the paralumbar. And of course, we're going to be on the left side, ideally, because the kidney sits a little bit more caudal. But if we're on the right, it's okay if the animal gets laid down on the wrong side. Third is going to be bladder, and fourth is going to be umbilicus, which is slightly misnamed because we're going to be just below the umbilicus, halfway between the table and the umbilicus, but it gives us a good reference point. The letters you see in parentheses are the longer names for the internal targets. They are the diaphragmatico-hepatic, the splenorenal, the cystocolic, and then the one that originally got misnamed, they have changed it, but it's even longer, but historically it's been called the hepatorenal site. We don't look for liver or kidney. We actually look for small bowel plus or minus the spleen. So at all these locations, except for this one, the subxiphoid, you want to watch your pressure. But for this one, you actually do have to push in pretty firmly. So what you're going to do is hold the transducer, and I'm just going to pick up my phone real quick. Hold the transducer like this. When we're working on top of the animal, I find holding it like a pencil is easier. But when we're down at the umbilicus and subxiphoid, you want to do this because it's going to be more ergonomic for your wrist. You really want to avoid doing this because it's going to tire yourself out. So you're going to orient that probe marker toward the head. You're going to push in pretty firmly, then angle cranial. And the reason for the push in is you're establishing good transducer contact with your skin. Of course, you've already put alcohol, you've already parted the fur. One of the things you want to avoid is just putting the probe on like an angle. If you do that, you actually trap gas between that cranial aspect of your transducer and your skin, and the entire right-hand side of your image is going to be black. So push in, firm, Angle cranial, so you see liver, and ultimately what you're trying to see is where the liver is touching the diaphragm. If you do not see diaphragm, you are not cranial enough. The diaphragm, which is technically the diaphragm lung interface, is going to be this hyperechoic curvilinear line. Liver is going to be gray. Gallbladder, if it doesn't have sludge, will be black. If it has sludge, it may be a little bit gray. And sometimes we will see the caudal vena cava, sometimes we won't. It's okay if we don't. Stomach, depending on how much is in it, will be caudal on the image. I do like to point out all these machines have a depth gauge, and typically it displays in centimeters. They also, a lot of them, have focal zones, and that focal zone is going to be placed at or just below the region of interest. For a liver, we're going to want to keep it pretty low. Okay, so when we go to interpret normal, I should not see any anechoic structures that are not oval, round, or tubular. All right, sure, there are always going to be exceptions, but 99% of the time, if something is normal, it is going to be oval, circular, or tubular. Let's look at examples. We have a gallbladder, it's oval. We have small little vessels here. These are round. We have a big vessel that's tubular. Okay. When we contrast that with peritoneal fusion, it's going to be triangular or irregularly shaped. So here's an anechoic triangular pocket. This is a little fluid pocket sitting between the diaphragm and the liver. Equally on this side, we have a larger volume. This is just an irregularly shaped fluid pocket sitting between the diaphragm and the liver. Now, one important thing to note, at all four of these locations, most of the time, if fluid's going to form, it's going to form on the cranial aspect of the organ first. And so what that means for you, it's going to form usually on the left. This is why it's really important that we angle cranial when we're doing that subxiphoid location so we don't miss this pocket. If we weren't angled cranial, we might cut our field of view off here and we would miss this positive finding. So when I'm at the subxiphoid location, in addition to looking for peritoneal fusion, I actually look at three things. I'll only put two here because the third's considered a little bit more advanced technique. I'm also going to evaluate the gallbladder, and we are going to talk about that in this lecture. The other thing, just don't forget to look across the diaphragm into your caudal thorax. There's not a lot more to talk about than that. You want to make certain you don't see obvious pleural effusion like we have in this image. You will sometimes see pericardial effusion. There was a nice study done, and when pericardial effusion was present in their patient population, you could see it from the subxiphoid 83% of the time. When you didn't, it was a small volume and you found it on your thoracic point-of-care ultrasound. And then finally, I've been unlucky enough to find some pulmonary, mediastinal, and esophageal masses from this location. But wow, was that valuable information, because those animals were presenting with vomiting, diarrhea, GI signs, et cetera, et cetera. The third thing I look for, you can, once you get more comfortable with your technique, evaluate the patient's volume status / right atrial pressure by evaluating the caudal vena cava, but we're going to table that for a more advanced lecture. So when we follow now to our second location, we finish subxiphoid, we're going to get through our technique, then circle back to gallbladder. But to continue our exam, we're going to go up these floating ribs to where they contact the hypaxial muscles. If you put your transducer perpendicular right there, you're going to see the kidney most of the time. When you don't see it, you just have to angle cranial just a little bit. The ideal is to see the left kidney and hopefully the spleen, but sometimes that spleen doesn't want to play. It's shy and it flops over to the other side. But if it does, it's usually going to be sitting down here in this umbilicus location, and we're still going to find it. Okay. So this is our classic textbook view. We're going to have a kidney, which is a retroperitoneal structure, a spleen, which is peritoneal. Stomach may or may not get in the way depending on its contents. If the kidney is too big to fit in your field of view, then just focus on that cranial half or third. Why? That's where fluid likes to form. And again, I'm looking for any fluid that is triangular or irregularly shaped. So on the left, we have a small volume. We have the white arrow annotating a small triangular or trapezoidal pocket of anechoic fluid. It's between the kidney and spleen. And on the right, we have a really nice image of a large pocket of fluid surrounding the spleen. Now, I always like to point out, remember, the kidney is retroperitoneal. That fluid should never dissect all the way around the kidney. It's only going to contact part of the surface. It will surround spleen, small bowel, stomach, but not kidney. If you see fluid going all the way around the kidney, that indicates it's retroperitoneal effusion. So this is another example of something that we're going broach at the very end, and that's incidental findings. The nice part is if you start doing enough of these, you're going to start to learn, oh, this is what a normal spleen looks like. This is what a normal kidney looks like. And even if you aren't confident making the diagnosis, on the video on the right that I'm showing, very clearly we have this spleen that's normal for an instant, but then it segues into this large irregular mass. And you don't have to use lots of radiology terms. You can just go, oh, that's an ugly gray mess. That shouldn't be there. And even just being able to say that shouldn't be there is important because it can help guide further diagnostics. If I told you this was a 10-year-old golden retriever, you automatically know what's going on. This is probably a ruptured hemoabdomen, right? And even if you don't have a lot of ultrasound experience, it's valuable information. So with incidental findings, the key is don't be afraid of them. Don't feel the pressure that you have to make the diagnosis. The key is just note it and move on and interrogate it with something else after. But that's a really, really good finding. Okay. Bladder. At this location, we're going to find that inguinal fold that I call it the little flapidoo, the skin that comes up from the femur and attaches. It's right here. This is the inguinal fold, the flapidoo. We're going to put the transducer perpendicular, boop, right there. And we're going to look down. I do like to point out a lot of people are used to looking at bladders and putting the transducer midline. That only works if they're on their back. If you put the transducer on midline, you're going to be looking over the fluid. It's like standing at the ocean, looking out at the ocean, but somebody put blinders on you. Okay. So we want to look down into the pocket. And the main thing we're looking for is urinary bladder. I love the urinary bladder because it is one of the simplest organs to evaluate, which is why we're going to talk about it at the end of this lecture. But it should have a thin hyperechoic wall, sometimes so thin it blends in with the surrounding tissue, and then an anechoic center. All right, that's the urine that's in there. If the bladder is big, again, put the urinary bladder, the cranial aspect, the apex, in the center of the screen. If fluid's going to form, as you've seen, it's going to form off that apex. So we've got wide arrows denoting a small volume on the left and a larger pocket on the right. Finally, we come to our home run location, the umbilicus. The highlighter is pointing to the final one. This is home plate for us. This is the umbilicus. This is the table. You're going to put your transducer halfway between the pink highlighted umbilicus and the table. At this location, we're just looking for a sea of gray. Technically, you're evaluating where small bowel is in the mid-peritoneal space, and this is the other location the spleen likes to come to, as you can see in this image below. So we are not here to learn the wall layering of the small bowel, but the one word of caution, the small bowel has a very thick mucosal layer, and that mucosal layer will look so hypoechoic, it sometimes looks anechoic. So I've got a zoomed in image just so you can see the yellow asterisks are on the mucosal layer. If we come to our image, it'd be real easy to look at this and go, oh, is this some weird effusion? Is this? It technically is hypoechoic, but the thing to keep in mind, it's in a circle or a tube. So we just have to know that and not mistake it. I have seen some people misdiagnose small bowel for peritoneal effusion. Remember, peritoneal effusion is going to be triangular or irregularly shaped. And this is a great example of some fluid hugging up against the small bowel. Here's mucosa, here's fluid. You can see they're very similar looking, but this is in a circle. This is a weird shape. And then this is obviously a very, very large pocket. Now, again, not going to talk about it today, but this location, the umbilicus, is the #1 location for sampling fluid. With an ultrasound, you technically can guide your needle into anywhere the pocket is contacting the near field. You never want to poke through other organs, but this location you can see would be a great place to stick a needle and sample it. This would be just like sampling a urinary bladder. Very easy to hit this large pocket. This, much harder. You want to practice before you start going after these, but over here, absolutely get some of that fluid. All right, now that we have our technique down, we know how to evaluate 4 locations in the body: the umbilicus, the flank, the bladder, and coming back. The umbilicus, the flank, the urinary bladder. I keep saying that. The subxiphoid, the flank, the bladder, and the umbilicus. Now we're going to apply that. And we're going to talk about a nice, useful way to semi-quantitatively measure the fluid that's in that abdomen. Unfortunately, with all the variations in belly size and shape, there's no way we can look, measure, the depth of the fluid and say, all right, this animal has 10 mil per kg of fluid. And that would be handy, especially in trauma, because we know once we get above about 30 mil per kg of blood loss, fluid therapy is usually not going to cut it. And we're usually going to need blood transfusions. So, fortunately, in one of the original studies that was done, somebody developed and validated an abdominal fluid score. And even though we're going to talk about it in the context of trauma, I think it's important to note that this is just very useful for your medical record keeping to keep track of how much fluid each patient has. As expected in dogs that have been hit by a car, blunt force trauma, hemorrhage is what you're going to see most of the time. In a small percentage of cases, urine, and rarely bile and bowel, so exudate. But most commonly, it's going to be the spleen or liver rupturing and bleeding. So the way this fluid score works, it's easy. You take your 4 locations. Every location you see fluid, you give that animal a point. So a normal score is 0, meaning there's no free fluid at any site. 1, it means you found fluid at any of the 4 sites. It doesn't have to be a specific one. It could be only at the umbilicus, only at the subxiphoid. 2 is 2, 3 is 3, 4 is 4. Okay. So as logic dictates, the more fluid you have in your belly, the more sites are going to fill up, especially if you think about the flank as being gravity independent. Unless you're bleeding at that location, it's a really hard site to get fluid at unless you're bleeding at the spleen, okay, or oddly at the kidney. So the higher your score, it is logical that more likely you have more fluid. The thing to note, though, this doesn't work out for every single patient. Every once in a while, we have those hypoalbuminemic patients or early septic peritonitis that they have a small volume. It's pretty evenly distributed, and you have 4 tiny black triangles. So for years, what I've done is I will put a little qualifier after my score. For example, if it is 1 out of 4 in a tiny black triangle, I will write 1 out of 4 small. Or if it's a large pocket by the spleen, because they just started bleeding, 1 out of 4 large. Okay. If it's 4 out of 4 and they're all tiny pockets, 4 out of 4 small. If there's a large volume, 4 out of 4 large. And it just helps, or mild, moderate, severe. Okay. Now, this AFS, this abdominal fluid score, has been updated to introduce measuring and half points. I will admit I'm not a huge fan of that, especially for people new to point of care, because as we start to measure, it takes longer, it becomes a distraction. So right now, starting out, just use a qualifier, but do note, if you keep pressing on with point of care literature, we can teach you how to make this a little bit more precise and to accommodate that small versus large effusion. So just a couple of clinical pearls with the abdominal fluid score. Know that it's going to be really useful for all your non-trauma patients. It was just part of my medical record keeping. I don't know about you, but I get 3 patients deep into a day, and I'm already starting to confuse them if it's not written down. I lived and died by my records. I walked around with a little either pad of post-it notes or a little spiral notebook, and everything got written, and then it went into my computerized medical record. So this score is a great way to track changes. In cats, it is useful, but we haven't validated it for trauma. We can't make the same predictions we can as we will sometimes in dogs. And then the other thing to note is this score is going to change in a lot of our patients. If we take trauma and hemorrhage, a lot of these patients come in and they improve. Some of them come in and they worsen. My record, I had a patient come in with an AFS of 1 out of 4, and 15 minutes later, because there was active hemorrhage, it was 4 out of 4. That to date is the most number of blood products I've used in one patient. I did a unit of my dog's blood, a unit of stored whole blood, and 10 auto transfusions. But that patient lived. And that's another important clinical pearl. We should never be using the score to make prognostic decisions. Even if a trauma patient comes in with a score of 4 out of 4, they can still be controlled. We know trauma patients actually have a good prognosis overall with appropriate care. So always consider rechecking. My rules are, if my patient declines for any reason, I'm going to recheck. And then routinely, if I have a patient I'm worried about, even if they haven't declined, maybe 4 to 6 hours after the initial. And then if they're pretty stable, usually my normal was to scan them a minimum of once a day at the beginning of my shift. Sometimes if they were a little bit less stable, at the beginning and the end of my shift, so I could hand off the status of the patient when I was working shift medicine in emergency medicine. All right. So serial exams, very valuable. All right. We now have that valuable skill of an abdominal point-of-care ultrasound to look for peritoneal effusion. We also have a way to semi-quantitate that fluid with our abdominal fluid score. Now we're going to go back to that subxiphoid location. We have already looked in the caudal thorax, but we're going to go back to the gallbladder. And this is going to be our first kind of focused exam. And it sets up great because the gallbladder looks identical to the urinary bladder, which is where we're going to end. The gallbladder is going to sit just right in midline. So if our patient's in right lateral and our probe is pointed straight, you just have to go down a little bit. That's where it's going to be. It's going to have a thin hyperechoic wall. We're not measuring it, but if you did, it would be less than 1 to 2 millimeters, and the lumen should be fairly anechoic. We know dogs love to get a little bit of hyperechoic sludge, so that may throw you off when you're new to ultrasound, but it should be anechoic. So the main thing we're evaluating for actually is the wall and the wall getting thick. Gallbladder wall thickening is a really, really important finding for a lot of our patients and has a lot of differentials that can direct how we work that patient up. Now, the emergency literature has fallen in love with naming everything a sign. And I'll admit, I have a little bit of a pet peeve. I don't like signs because sometimes people learn the sign but don't know what the sign is from a pathophysiology basis. So we're going to use it because it is so commonly used. This is referred to as a gallbladder halo sign. But I want you to know that a halo sign is gallbladder wall thickening. What happens when the gallbladder wall thickens is that you get this banding effect, and that's why they call it a halo. You get this hypoechoic band that looks like a halo around that hyperechoic thin wall. And a lot of patients will actually have two hyperechoic lines because edema is separating that wall out and making it thicker. So this is a great example of just diffuse gallbladder wall thickening or a gallbladder halo sign. When you find this, the important thing to keep in mind is it's not pathognomonic for any one thing. I have noticed every once in a while I follow some of the Facebook threads for emergency and imaging, and I'll hear people make the innocent but inaccurate comment, oh, if you see a gallbladder halo, it's pathognomonic for X. And I don't even want to say what X is because it always varies and it's not correct. It's not pathognomonic for anything. It's a very sensitive finding, but is not specific for any one thing. So the way I want you to sort of organize it in your head, it can be caused by inflammation or edema. There are other causes, but these are going to cover over 95% of the differentials you'll see. So when we think inflammation, it's all the things you guys as fabulous clinicians know. We're going to see hepatitis, cholangiohepatitis, cholecystitis, pancreatitis, even septic peritonitis or carcinomatosis, anything that causes inflammation in or around the gallbladder. The second cause or group of causes, which I think throws people off sometimes because we just don't expect it, are things that cause edema without inflammation, without cellular infiltrates. And these are going to be anything that disrupts portal vasculature, anything that backs up fluid into the chest, and anything that increases hydrostatic pressure. So when we look at some of the most common causes, drugs and fluid therapy are some of the more common causes. If I load an animal up on 2 to 3 times maintenance, I see this a lot. If I give Dexmedetomidine, more on that in a minute, you will see it. IMHA, we see it commonly because they are volume hypervolemic from compensatory mechanisms, and we often treat them with fluids and blood products. We see it with pericardial effusion, right-sided heart failure, and heartworm disease, and then finally low albumin, renal failure, and anaphylactic shock. The anaphylactic shock is interesting. It's a dog-only phenomena, but it happens because the liver and the GI tract are the shock organs. So when they go into shock and have that mast cell degranulation, they get a lot of fluid pooling that occurs that just goes into the splanchnic circulation. So really fun. Dexmedetomidine is something I've been trying to get out there and kind of chat with people about. I'll admit this is kind of a small area of interest for me. But where this came from is a lot of us were doing ultrasound labs and we use Dex to sedate all the time. And occasionally we would see this patient develop it and we'd start to get concerned. You know, are they sick? Are they developing anaphylaxis from the drugs? What's happening? It wasn't there at the beginning. And as it turns out, it just seems to be a phenomena related to the pharmacokinetics, or I shouldn't say pharmacokinetics, but the physiologic consequence of giving dexmedetomidine. So what we saw real simply, we did in a nice little prospective observation study. And in routine dogs getting sedated for radiographs, about 80 or 90 of them, at 5 mic per kg, we saw a gallbladder halo in 1/4 of them. So this is common. You are going to see it. Now, the nice part is it takes 20 to 40 minutes to occur. We did another study where we looked at some dogs we had, and we looked at them every 10 minutes. And this is not immediate. It takes a little bit of time for that blood flow to shunt. But if you do go up to 10 mic per kg, you will see it a lot more commonly. So it does appear to be related to the dose. It does appear to take a little bit of time. And the important thing to note is it doesn't reverse as soon as you give the aniseed, and it takes a while for the lymphatics to drain all that. So it can take up to 24 hours. Most clear it in 12, but it can take up to 24. Now, I get the question all the time, does this mean we shouldn't be using Dex? Absolutely not. Dex is still one of my favorite things to use for a sedated ultrasound. It just means you either need to A, look at your gallbladder at the beginning of the exam, or B, if that animal has gotten Dex within 12 to 24 hours of it seeing an ultrasound probe, note that you may find this, and it may not mean true pathology. Okay. The other thing that was not expected, Dex also appears to cause peritoneal effusion in about 1/3 of these patients as well. And when you look at the combined findings of peritoneal effusion with wall edema, that could be really concerning. That could be anaphylaxis. That could be liver failure. It could be right-sided heart failure, but it just happens from the Dex. Now, I do not know if this effect occurs with the same frequency with that new Dex drug. I'm not going to embarrass myself and try to pronounce it as a radiologist, but the one that has a much better cardiovascular profile, I don't know. I would like to look at that. So, gallbladder halo clinical pearls. Pay attention to your history. It's going to help guide you to what's causing it. Did we step in an ant pile? Did we get vaccines? Do we have a history of liver disease? Is there a murmur, etc.? Always, always, always perform thoracic point-of-care ultrasound. And then if we're not getting it based on our history and our thoracic point-of-care ultrasound, we may need to do diagnostics like some thoracic rads, blood work, etc., full diagnostic ultrasound. All right, so we will now transition into our second point of care technique, looking at the urinary bladder. So the big thing you want to consider is this is such a valuable technique in any dog that's having lower urinary signs, hematuria, plaquuria, and it doesn't have to be for the older ones too. I love this as a way to confirm that my empirical therapy probably won't fail. I always hated when I would do my urinalysis and I didn't do rads because the owner was cost concerned. We start an antibiotic, they're back 2 weeks later, disappointed it didn't work. We take rads and they're stones. Well, the nice part is most of us are getting a urine sample via cystocentesis. And if you're getting it via cysto, you might as well get it ultrasound guided cysto. Now, if you're doing free catch, this would be doing an additional thing. But for a lot of us who were trained to do the pour the alcohol in the belly and put the needle where it pools, this is a nice way to ensure we're sticking the needle where it's supposed to go. So the way I used to approach it, especially for people who might be a little bit hesitant about their ultrasound skill set, is you're not performing a diagnostic ultrasound. I would say, hey, Mr. and Mrs. Smith, I'm going to go do a urinalysis. I'm going to get the urine sample with a small needle, same one we use for vaccines. While I'm getting it, I'm going to use an ultrasound to make certain the needle goes into the bladder and only into the bladder. And while I'm there, I'm just going to look back and forth a couple times to make certain I don't see anything concerning that would warrant us doing more tests tonight or would cause my initial plan to fail. Now, if we see something, we'll need to do radiographs or a full ultrasound, but the ultrasound, the point of care ultrasound will be a nice way for me to just spot check and make certain that our plan today is going to fail. And that's it. You don't have to come up with a diagnosis. You could look and go, not normal, and then go in and recommend rads. So the goal with point of care isn't always to make the diagnosis, it's to trigger a next step. So typically I'm going to do this before I cysto because cysto can cause a little bit of bleeding or gas in the urinary bladder. So I'm going to put the transducer on, and guys, this is how simple it is. I'm going to hold my ultrasound and I'm going to fan back and forth like this. Boop, boop. So side to side, I'm going to do that at the apex and do it caudal. You're going to fan back and forth till that ultrasound disappears from the field of view, both directions. Now, if you want to turn and do transverse as well, go for it. But honestly, I think you probably only need to do it in sagittal as well. Just make certain you do the whole bladder because sometimes stones will accumulate back by the neck. Sometimes the apex, you got to get the whole bladder. So cranial half, back and forth slowly, caudal half, back and forth slowly. That simple. Okay. One rule I have, never, ever, ever trust a small bladder. Now, this is a bladder that we happen to have a catheter in, so I was able to instill it. But what I hope you see from this, when it is collapsed, it is really hard, one, to recognize that as bladder, but two, to really appreciate how much stuff is in it. It's also hard to see small masses or nodules. So the common situation I was in, you'd have those fluted cats come in, they're peeing every 2 minutes. Their bladders are often going to be empty. In those animals, sometimes what I would do is I would say, hey, I can't get a urine sample. I can't evaluate it. I'm going to start empirical therapy for interstitial cystitis. Bring your cat back in 3, 5, 7 days, whatever your interval is, and recheck our point-of-care ultrasound at that time, get our urine sample, send it off, make certain we're not overlooking crystals, infection, something of that nature. And it was just a nice way to ensure that, yeah, we were treating idiopathic cystitis and it didn't fail. It also helped bring that animal back to us for a recheck to make certain that they were improving. So when we're looking at the bladder, we're going to look at two things. Is there stuff in the lumen? And is the wall thickened? It is that simple. When we're looking at stuff in the lumen, it can be little sparkly bits. And notice I'm not using the radiology terms. Yes, I can look at this and say there are numerous hyperechoic foci freely suspended, but say sparkly bits. That's okay. There are lots of hyperechoic things in the bladder. They can be anything. They're not pathognomonic for anything. They can be cells, protein, sediment, hemorrhage, but it's an important finding. Now, in cats, they often secrete lipid into their urinary bladder, not secrete, excrete through the renal tubules. And so if I have this degree of sparkly things and it's a non-urinary history, I'm going to ignore it in a cat. Dogs even, I don't put a lot of credence in occasional things if they don't have a lower urinary history. Blood clots are going to be bigger and more structural. On the left, I've got some smaller ones that are gravity dependent. On the right, we have this big one. And the reason why I have this one in here, if you look at this, I want you to go, oh, I would have called that a mass. That's huge. And it's by the trigon. And you know what? This is where it is fair to call it a mass. Mass doesn't mean neoplasia, but it is a mass of tissue. And this is where I think it's important with point of care. We don't get hung up in making the definitive diagnosis. Use your signalment. This is a 2-year-old dog with a thrombocytopenia. This is probably going to be a blood clot. This is a 12-year-old dog that failed antibiotic therapy. This is probably going to be a tumor. Now, the nice part about blood clots, most of them will reabsorb within 24 to 48 hours. I don't have a study on it, at most a week. So if you're in doubt, recheck it in 2 to 3 days after some therapy. If it's still there, the same size and not moving, start your BRAF testing or your traumatic catheterization. Stones are going to be hyperechoic and they're going to have that clean shadow. They're usually going to be gravity dependent, but occasionally they will adhere to the wall. So here's some nice stones with shadowing. It can be a little bit hard to differentiate colon from stones, but just remember colon's going to be outside the bladder. And if you change that animal's position, colon will stay fixated, whereas the stone will move. So this is an animal that was in dorsal because it was safe to do so. The stone fell down. We changed their position. The stone moved closer to the transducer. Then finally, we're going to look at the wall with cystitis. As expected, that wall is going to be thickened. Usually with normal cystitis, it's going to be thickened along the apex. With dogs, we all know it's going to be bacterial most of the time. In cats, it's usually going to be sterile. But once they are over the age of 10, their incidence of UTIs goes up a little bit. Polypoid cystitis is just that little reminder that if their infections are bad enough, they will develop these little polyps and they will resolve with antibiotic therapy. So remember, not all polyps are cancer. If they culture positive, I would absolutely treat this and follow these. And if they're improving, then probably not. But if they're not improving and or BRAF positive, then obviously that is concerning for neoplasia. But finally, the big one, and one of the biggest reasons I love point of care screening, is making certain I wasn't about to send an animal with a big mass home on antibiotics. I always got red flags when that 12, 14, 10-year-old animal came in with hematuria that's never had a history of a UTI, especially if it's a male. And you take radiographs, you're not seeing it. And if you don't have access to ultrasound, how are you going to get to that diagnosis? Well, with point of care, even if you are not confident committing to it, it at least triggers or gives you some confidence to say, hey, we need to do BRAF testing, or we need to get you in for a full diagnostic ultrasound. As you know, TCC is most often at the apex, at the trigon in dogs, but it can be anywhere. It is most often focal or mass-like, but it can be multifocal or diffuse. In cats, it's actually more commonly apex or body. But just be on the lookout. It has lots of varieties. So this is our classic trigonal mass. And then ending our last couple slides, we have kind of a pedunculated mass with mineralization, and we have a polyp with diffuse thickening. All these were confirmed TCC. So where I wanted to end this, and I won't take too long because I want to leave 10 minutes for questions, but make certain if you are really, really committed to point of care, you make time to do it. Batch it into your sick fees. Practice on dentals and spays. Get owner permission, but say, hey, I just bought a new toy. Can I practice? Most owners are going to say, yeah, can I see it? Pull it out, show them, practice in the room. Say, hey, I'm just going to fan through. This is cool. You can put it on your wrist. I found when I was learning new stuff, most owners, when I talked to them openly about it, what I was trying to accomplish, were very supportive of that. You also may want to consider getting a second unit. Finally, have a business plan. I find vets were always really good and we're a little bit hesitant to want to charge, but it's okay to charge for what you're doing. So charge for cystos and practice your ultrasound guided cysto. Then start charging for ultrasound guided cystos and practice your point of care bladder exams. Then charge for those and practice a whole point of care. So just keep building. But what I'm trying to demonstrate is that if you don't charge, you're not going to pay for that equipment. And just with a little bit of mindful charging, if you charge a $50 abdominal point of care, which arguably this number is probably old and out of date, it's probably a little bit higher now, but $50 a day, doing one a day, 4 days a week, you've just bought a handheld unit. You're done. And I'll be honest, I was usually doing 2 to 3 in GP, 3 to 5 in ER, sometimes more. If you've got 3, 4, 5 doctors, all of a sudden, this is a very profitable piece of equipment that pays for itself in a couple months. So again, I try to bring up the business aspect because I want you to know I was in that world. It's not all about the academics. We can't just spend. I had a really good boss who only let me buy stuff if I had a business plan, but she did. And I always came through and I always generated revenue with that. So with that, I would love to answer any questions. For those who use the hand raising function, if you don't mind, put it in the chat and we'll tackle some questions.
Thank you again, Dr. Marc. This was fantastic. Good feedback already. It looks like, let's see, do we have some questions? Yes, so this has been recorded, so it's going to be available for everyone to watch again. Again, it's a lot of great information hearing Dr. Marc talk. What questions do you have about the presentation? Anything particular we can answer for you tonight?
I'm seeing I'm probably going to mispronounce it, but Merced, I apologize if I'm mispronouncing your name. Do you mind throwing it in the chat what your question is? If you didn't already. All right, Sally so this is the drug I was trying to think of, the medetomidine. Is medetomidine the newer one you're talking about? If it's the newer one you're talking about, we don't know. We don't know. We haven't studied it yet. I would imagine it could to a smaller degree, but it's probably going to be less frequent, but be watching for it. The big thing to know, it is reported with more than just Dex. We've seen this with, I think, morphine. So anytime we're altering cardiovascular status, cardiac output, gallbladder wall thickening could occur from stuff just pooling in the splenic circulation. Oh, so medetomidine, you're referring to the generic and the older? Yes, I would expect it from that. I haven't specifically studied it, but the pharmacokinetics are identical to Dexmed, so I would expect it as well. I would expect it, honestly, from any of the alpha 2s, but we haven't studied each one specifically. But one author reported it with morphine, which surprised me, and it was not related to anaphylaxis with morphine. It was just a sedation. So I imagine we're going to see this more and more. Don't quote me, but I feel like I've seen this with alfaxalone, but that is not coming from research. Okay. Good question, Sally.
Okay. So I see a question about PDF form. If you'd like a PDF, you can reach out to me. I'll put my email address here in the pod and I can forward it on to you.
Yep. David's got a copy and I'm always happy sharing my slides. I just ask obviously that you don't reproduce them, but I am very fine with you redistributing them to people in your clinic. Because if this helps somebody in your clinic, please. If I didn't emphasize it enough, please rope your technicians in. I think I did forget to say that it was on the slide, but technicians should absolutely be doing point of care. I hope some were logged in, and please get them trained as well. All right.
Terrific.
Casey is asking, would you use this as a pre-diagnostic tool if we see something questionable? So yeah, like I treat it. I think this is what you're asking as a screening test. I've often, when I was early in my career, looked at rads and gone, is that a mass? Uh, extended point of care. Or, you're doing your point of care and you see a mass that triggers doing that next step. Having that doc come in to do a mobile ultrasound or whoever does your mobiles. I think that's what you're asking, but if not, please elaborate again. But now I will say, I am not, and this is a little bit of a soapbox / controversial topic. I'm not a fan of most routine imaging as part of geriatric screens / just health screens. Human medicine is tackling this, and we have created a lot of screening tests where we actually hurt more humans than we do help them. And I think it's a slippery slope. Like doing an imaging test in an animal that is clinical or symptomatic makes all the sense in the world. Doing it in an 8-year-old golden because it's an 8-year-old golden, you got to be real careful because you will find abnormalities. And a lot of abnormalities we find on ultrasound are not clinically significant, and they will lead to tests which spend money, waste time, and increase complications. So I will fully admit, I don't recommend this for just routine geriatric screening unless there's a clinical history. Now, they come in for their annual and they're like, oh, my pet's been more lethargic. Absolutely, you should do it. If it's an 8-year-old golden and you're just being breed racist because it's a golden and they get hemo abdomens, not a good reason to do it. Oh, how much fluid should be there for tapping it comfortably? That depends on your skill level. So because we're dudes, me and my residents, actually, what am I saying? Everybody, the ladies and the males, we very much have competitions of who can hit the smallest pocket. With skill, you can hit mil per kg, easy. Now, in the beginning, go by not mil per kg, but how big it is on the screen. I would say you want a 3 to 4 centimeter pocket about the size of a bladder up against the near field. So if I'm using my screen, you want your fluid pocket like this. Then as you get better, that pocket can get smaller and smaller. If you haven't started doing it, practice with fruit cups. In the beginning, you can stick the needle anywhere in the fruit cup, but eventually you want to get to where you can hit a single grape in the fruit cup or pear or peach, and then eventually a single surface of a single fruit in the fruit cup.
I like that.
We have competitions. It's fun. All right. When aspirating, and David, you cut me off when I have to stop, but when aspirating fluid from a pocket, are you using the cranial marker as a point of insertion or the caudal side? Lauren, me personally, I use cranial because I was trained traditionally, but I am one of the radiologists who teaches the anti-tradition, meaning I want you to do it the way that is safest to you and do it that way all the time. I have a resident who comes in the caudal side, and it drives everybody mad, but he does it and he is great. And like, I'm fine with it. I'm like, have fun, bud. You're doing great. So I think it's easier to do cranial. The other thing is some people say, oh, you should hold probe with dominant, needle, non-dominant, vice versa. Do whatever is most comfortable. Again, because I'm traditionally trained, I hold transducer dominant, needle non-dominant. But if you are safer swapping that, do it. I do think it's easier to look on the cranial aspect, but there are some times because of where the fluid is, I have to come in the caudal aspect. So be free. Just the big thing, here's what's great about ultrasound. You can see your needle. So as long as you know where your needle's coming in, cranial or caudal, and you can see it, it doesn't matter. Put the needle where it needs to go.
That's wonderful, Dr. Mark. Thank you so much for a fantastic presentation. Always enjoy working with you and hearing you talk. You have such practical advice and make ultrasound seem so approachable. Someone who was on the webinar yesterday actually said that to me. So
Oh.
That's really our goal. And again, a treat to have you. Thank you, everyone, for joining us after probably your long days of work.
Yeah.
Really appreciate it. And we'll be sending out your CE certificates to the email addresses that I have. And also we'll send the link to the recording. Okay. Thank you very much. Have a good night.
Good night.